pleasure of knowing her for a number of years, had the pleasure of picking her brain, both at my other place where I was employed and then, of course, here. She's called in a number of times. A lot of you have responded very positively to the conversations we've had. And so we've decided to expand it a little bit by trying to, get a little bit of her time once a month or so. She's right down the road, really, so it's not like it's out of her way. But nonetheless, we appreciate Dr. Seabrook, Dr. Janet Seabrook, taking time out of her busy day to come in and hang with us. So with that being said, enough of me, more of her. Good morning.
Good morning.
Let me cut your mic on. See, that's how it works. I'm an amateur.
Morning. Good morning, Jeff. How are you?
I'm doing great. First and foremost, let me say happy holidays and happy New Year. I haven't talked to you since we had the New Year, so I want to say that. Everything going good?
Happy New Year to you.
Yeah.
And yes, so far in this new year, things are going well.
Yeah.
2023 is in my rearview mirror.
Absolutely.
And I want to look forward to a positive 2024.
Yeah, I think it's going to be great. I mean, one of the things I think we talked on the phone about the last time is one of the things that's amazed me, and I drive around and I'll just be talking to myself in the car and people think that, something's going on with that dude in his car talking to himself. And they could be right, but a lot of times I pass a community health net and I'm just like, you know what, the footprint of community health net has absolutely gotten large. I mean, you really have gone out here and provide a staple. And when I pass these facilities, there are cars in the parking lot. So people are utilizing your services that you provide. I mean, how long have you all been in existence? 20-some years?
We've been in existence since 1998.
Yeah.
State-funded health center, and then in 2006 we became a federally qualified health center.
Yeah.
And we currently have 8 locations throughout Northwest Indiana, and we're in the process of partnering with Westside Leadership Academy,
Right.
and to open a school-based health center at Westside, and also with the East Chicago Community School Corporation. So that will bring us to 10 locations.
Wow.
In Northwest Indiana. We're continuing to expand our services. We offer chiropractic care.
Oh my goodness.
As well as
dentistry
optometry care, dental care, behavioral health services. We try to have services available to encompass all the needs of our patients.
Yeah.
Sort of like a one-stop shop.
Yeah. Now, I mean, do you take pretty much all insurance?
We take all major health insurance carriers as well as Medicaid and Medicare. We do have quite a number of senior patients.
Right.
They've been with us for a while. And
they count on you.
Yeah, and they don't intend to change services and healthcare providers. There's a lot of competition in the market right now.
Oh my
so
God,
we want
yes.
to make sure that we're providing the services that our patients are saying that they need.
Mm-hmm.
And that includes those services, that we mentioned earlier. And we like to take that, patient-centered approach to healthcare to tailor our services to the needs of that one individual patient.
Now, I don't remember, I think I asked you this back years and years ago when we first met and started talking, but I mean, what is your specialty? Are you a general practitioner? What did you get into? What was your field when you first got into medicine?
So I trained in family medicine.
Okay, family med.
So what that means is I can take care of you from 0 to 100.
I know you can. And so in that vein, what have you seen change over the number of years you practiced? Because from somebody who's watched from the peanut gallery, because I'm very concerned about medicine, I satellite around it a little bit, but it's just been interesting to watch some of the trends and things like that have come and gone. And now we're getting into things like telemedicine. Doctors are finding themselves now, patients want a more one-on-one relationship, but yet and still you still have to provide accessibility to, you can't forget about those people in the rural communities, the underserved communities who need that clinic out there conveniently located and things like that. So what have you seen change as far as healthcare, and more importantly, how the government is dealing in it?
So what I've seen over time is a decrease in the number of physicians,
Yeah.
the number of medical students who are being encouraged to go into primary care. With the high cost of going to medical school, a lot of students chose specialty care, like
Absolutely.
orthopedics
Yeah.
and ophthalmology
Yeah.
and those specialty services that they can get the reimbursement so they can pay back those school loans.
Right.
We come out of school sometimes in debt anywhere from
I was
$250,000
about
to
to say.
$500,000.
Right.
And so those specialty services, cardiology,
What is that?
thoracic surgery, medical school is expensive.
No, I know that, but at this point in time, listen, I can even tell you that back when I was down in Tuskegee, they were floating things from the ag department, for veterinarians, for veterinary school, where they were trying to make sure that they had enough people that were out there to be able to serve, coming up in the future. Medicine's a no-brainer. Why are we going to the point where it looks like we might one day have a shortage of physicians that go out here per person?
No, it's not one day we might have.
We
are
there.
in a shortage
Yeah.
right now. The city of Gary itself is considered a health professions shortage area and a medically underserved area.
What?
We have a shortage of primary care physicians in the area. So, which is one of the reasons why I've been an advocate for bringing residency programs to Northwest Indiana. And so I've been a part of the Indiana University Northwest Consortium for a number of years, since 2014 or 15.
Nice.
Where the conversation started at that time to form residency programs throughout Northwest Indiana. And I don't know if many people are aware that Methodist Hospital a number of years ago had a residency program, a very strong residency training program.
Why'd they get rid of it?
Unfortunately, there were some advocates that believed that family medicine, should become internal medicine, which is
it's a whole other thing.
Yes.
Yeah.
And so, needless to say, the program had some challenges, and currently, right now, Community Health Net is partnered with Methodist Hospital to revive and revitalize and bring back the residency program to Methodist Hospital and have those residents there in training. I'm so very excited about it, because studies have shown that 82% of people who graduate from residency programs stay in the area.
Yes.
Now,
we see it in Indianapolis all the time.
When we had the program, the majority of our providers stayed in the area, and guess what? Many of us are still here.
Yes, yeah.
But as we start to, the word I don't like to use, as we start to senior ourselves out, there aren't a group of young primary care providers to help replace us. So I think it's very imperative that this program be brought to fruition, and I'm very hopeful that it will be. I think the hospital is doing interviews right now for program directors. So I'm very excited about that.
Yeah.
And just, hopeful that the program will be able to get into the match coming up in 2024, and hopefully have residents there by 2025.
Let me tell you, I'm glad you brought this up, and probably, I guess there are people listening that would assume this is no coincidence, because I talked about this. I brought this up yesterday with Dr. Frink, but I want to take it a little further because I want to ask you this question, because one of the things as we look at a community like Gary, and I'm going to use Gary as a great example because it is a perfect example for this. If we're trying to grow our talent and get our talent to come back here, we need public safety people, we need police, fire, as you just indicated, we need physicians. Why don't we start the process of farming talent, much like sports leagues do when they go down into the youth? And so what I was asking Dr. Frink yesterday from Indiana University is, why haven't they, and I brought your name up, are there conversations with physicians here, the school districts, to create some form of how when we got to college and undergrad, we had pre-law, pre-things and things. Some students came from districts where they had those programs in high school. And so what we can do is we can identify young people, help young people identify themselves as people who might be very interested in the medical profession. By the time they get to high school, put them on tracks in which not only, maybe for some community service hours, you can figure that out later, they can shadow some physicians on weekends or sometimes when it's not too bothersome or whatever the law allows, but they're also taking classes to prepare them to go into these programs in undergrad IE and IUN, or if you want to go anywhere else. And then IUN has a 4-year medical school right now. You can put them on tracks where they can be identified by the professors, the administration, and you can track these students. You know who they are, and by the time it's time for them to apply, you know exactly what you're getting, and they know exactly what's expected of them.
So when did you get in my brain? I gave this idea. I can remember talking about this as early as 2013 or 14.
Yeah.
Identifying students, adopting those students.
Yes.
So by the time that they get to Indiana University Northwest, if they agree to stay in Gary, we will pay for their undergraduate and their medical school.
Yeah.
If they agree to stay in Gary for the 8 years that we gave you and pay, you were in my brain.
Yes.
I've been talking about that for years.
Yeah.
At that time, there wasn't a lot of buy-in. I think that as we start to see changes in the city and people start to see, areas of hope.
Right.
I think, and the growth and collaboration of the relationships between the community partners.
Right.
Like Indiana University, like Methodist Hospital,
yes,
like Community Health Net and the other federally qualified health centers, city administration.
Right.
And so I think that in the body politic, so to speak, I think that we will start to see some changes. And for people who have been waiting for it for so long, you kind of get tired.
I know.
But you get we're always talking about it, but seeming to not ever go anywhere. But I honestly believe that that's going to change, and I think the impetus could be the residency program itself at Methodist Hospital.
I think you can package it perfectly. I mean, you can tell I've thought about this a lot.
Yes,
but,
I can.
But I've seen it happen in other places, and I remember even bringing it up many years ago to some officials in government. And I'm just using Gary as an example, for instance. Now, if Methodist Northlake, you had a residency program, you're getting young professionals out here, they're doing their stuff and things like that. Why not also, I've always thought about this, creating a model home. This is the city's investment in order to bring a middle class, create a model home of Horseman. Horseman has some beautiful homes, real close, right by. That way you get people don't have to think too much and navigate about where they're going. They're Methodist, they go to the Horseman area, they live in community, and get a model home and start trying to get people to move in through that program. Offer some home ownership incentives through the city because you want to have physicians kind of live and be in your community. I mean, I can think of so many great ways to package to bring everybody involved on board.
No, and you just think about it, back in the day,
yeah.
And I'm talking about, I was probably little or maybe not even born, those houses that were surrounding Methodist Hospital were doctors'
Yes,
homes.
that's where that
some of them, they have elevators,
yes.
3 floors,
yeah.
huge garages. So, they belong to,
I had 2 aunts, that's how I know. I'm thinking about that. And they were executives' homes, and they were for U.S. Steel. And so it would be, you could easily put together these packages to make this very worthwhile to the individuals involved. So, I think great minds think alike. That might be some Tuskegee in this. But, I think it's a great idea. I'm glad you brought it up.
I envision, and I know this is like total wishful thinking, but you've been to University of Chicago, right?
Absolutely.
Okay, and they have the University of Chicago lab school.
Yes, my wife taught there.
and people clamor to get their kids.
Yeah,
in
my
the
wife
lab school,
she taught German there.
And they reserve a certain portion for the professors and people who work at the university. Why couldn't we have a lab school attached to Indiana University?
Thank you.
And in that way, in conjunction with
we could do it.
School district,
yes.
The lab school.
Yeah.
We build the school district back up.
Yeah, we're gonna have to
professors and
we're creating stuff
and
here.
Lawyers. Yes, we are. Then here come the restaurants, here comes the franchises, here comes the entertainment.
Thank you. There you go. Let's
we just solved everything.
We just solved everything right here. We're talking with Dr. Jen Seabrook. She's hanging out on Wake Up GR with Jeffrey Smith this morning, and we're having some pretty interesting conversations. Obviously, she's the proprietress of Community Health Net. They got 8 locations. They're all over Northwest Indiana doing great work. We were just talking about the healthcare profession, and I know I've picked your brain on this before, but I want to get your thoughts again on this, because I was talking to a young lady last week who was on the show, Dr. Regina Beard, who's she's a nurse. She teaches and things like that. But I love picking brains and teasing Roland and my boy Colby, who are doctors as well, about the emergence of the nurse practitioner. Let's talk about that, because is this something that was born of necessity, or is this the new way that healthcare is going on the one-on-one level? Because I always give the example. Taking care of my mother, I learned so much about, medicine, human medicine, that is. One of the reasons I remember my little mantra when I went to Tuskegee, while I had a lot of friends that were going off to medical school or other things, and they were like, why would you even, I loved animals, I'm only child and things like that. But one of my main things I used to tell myself to help me sleep at night was I didn't want to deal with the human beings and things like that. I could only imagine. And then when I got to Tuskegee, one of the mantras that we used to say in the halls, and that we used to use this to pick ourselves up, was that, we're the, I don't know why everybody else gives human doctors all this. We have to deal with patients that don't necessarily tell us what's wrong with them. Mm-hmm. So it was a whole little thing that I used to play in my head. But one of the things that I got an opportunity to do, though, fast forward, was take care of my mother. It was one of my greatest accomplishments when she was sick and suffered from dementia and some other health issues. And I got very close to her doctors. And one person in particular that emerged during the latter years of her care was this one woman who was her nurse practitioner. This woman, literally, when I tell you she lived out of her car, or her car was her office, I'm not exaggerating. I think she lived in Valpo. When snow was on the ground, she was always available and things like that. Now, the doctor that she worked with was a very good guy. I mean, he was very considerate, but he also seemed to be willing to defer a lot of the responsibilities to her. And so what I want to ask you, I know that's a lot, but when did that emergence, when did that divergence of the nurse practitioners start to evolve? Because I know there always were RNs and head nurses and, nurses that worked very closely with doctors, but all of a sudden it just seemed that it just went another way academically, and then they started being able to practice, prescribe medications and things like that, and they became somewhat of a surrogate. When did that happen?
So it came out of unfortunately, it came out of the need for primary care doctors.
Okay.
And with the shortage of primary doctors, the upsurge in nurse practitioners, which are nurses that have a 4-year RN degree, and then they go to school for some additional years to get their, they can either get general nurse practitioner, advanced nurse practitioner, and then some of them even go on to get their doctorate as a nurse practitioner. I think that, like I said, it came as an outcome of having shortage when the residents were being,
it came out of a vacuum.
Medical students were being directed to specialties, and so it left this void, so to speak, in primary care. And so right now, nurse practitioners in the state of Indiana are able to practice independently with a physician, who is their collaborating physician, meaning that those papers have to be signed off.
Yeah, he's kind of like their sponsor.
And then they have to go down to the state. And so their licenses are attached and things like that. So I think that it's more of a supervisory role, but it came out of a desperate need for primary care physicians. When you look at some rural areas that don't even have an MD in the area, they have to depend on nurse practitioners, and sometimes that MD may be 5, 10, 15 miles away from where the patients are. And so those nurse practitioners, using the word that you use, surrogate, can be a surrogate in that respect. I think that when it's done under the proper circumstances, meaning that, a physician has gone to medical school.
Absolutely.
4 years, and then had additional training as a resident to go into that primary care area, I think it's very important to make sure that there is some oversight along with that collaborating agreement. So I think that when done the right way, that it
can work. It can work. So what would you tell aspiring young medical professionals? I mean, because as I said, the reason I'm asking this is because if I was kind of coming up and I was interested in medicine, there's so many different ways to move inside the medical field now than they were that are not clearly defined. So if you were talking with young people that were sitting back and say, listen, medical school going on, everybody knows the grind of medical school. Make no mistake about it. But the closer you get, when you start to look at the dollar signs, even if you've got all the grades and you realize, like, okay, if I'm going to do this, I got to finish it. I got to do it right because I'm putting myself in some debt. And so when you think about that and you're talking to young people, what would you say to them about navigating and which is the best way? Or would it be a fit that applies to how you want to operate in that space?
So it's funny that you mentioned that because the current crop of medical students are totally different.
Yes, they
than
are.
we were. So they're sitting back and observing.
Yeah.
And they're seeing, okay, no, I don't see any life-work balance.
Yeah.
And they want to have life-work balance. They want to be able to go to work, do what needs to be done there, and then come home and shut it off.
Yeah.
And spend time with their family or
Right.
friends. And so
real quick, I want to interrupt you. I'm sorry because to your point, I heard somebody the other day, a physician out of Chicago, who was talking about this, and he says, like he's a young guy. This guy's he's like 33, and he's like his goal is to do 3, maybe 4 at best days in the week, and then he's done. He wants to be able to go travel, ski, and do all this other stuff. But he's looking to put 3 days in. I'm like, what?
No, actually, it's very difficult now to recruit.
Yeah.
Because they're looking at, okay, when is my next on call? They need to see, at least 7 to 8 other providers that are going to be taking calls. So that means that they'll be called 1 in 8, 1 in 6.
Yeah.
They want 1 in 12 call. The more doctors you have, the less calls you have to take.
The less calls you have to take.
So they're looking at all of that. Big salary.
Yeah.
Less time.
Less time.
Work, and, where's my administrative day? So, it goes on.
Work smarter, not harder.
Yes. And they're taking that to another total level that we never even thought about.
But there's a reality.
4 a.m. My husband gets up at 4 a.m.
Yeah.
He's in private practice.
Right.
4 a.m. 5 o'clock, he's out of the house.
See,
he's inside the hospital by 5:15. Does his rounds at one hospital, goes to the other hospital, finishes rounds there. He's in the office between 8 and 8:30. 9 o'clock, he's seeing his.
See, that's what I used to hear. and so like I said, what do you, when you're speaking to young prospective, medical professionals, how do you like reconcile that? Because one of the classes, it was a 2nd-year class at Tuskegee, was practice management. They wanted to make sure you got that under. If you're going to a small animal, they wanted to get you understand early about what it means to go out here and do it. So you can kind of tailor yourself. Everybody wants to go out here and be Dr. such and such in the community, but there's a lot that goes into it, a lot of hours, a lot of accountability, a lot of expenses going out, fully staffing a hospital. And so how do you reconcile that with some of as you said, these new attitudes? Because you have built a practice. I know when you came out, you were grinding. We don't even want to talk about it. People look at Dr. Seabrook now and they see your name attached to so many different things and all these 8 locations. It was a grind to go out here and do what you did. And still you're competing against other doctors that are grinding. And, I don't know if you ever attached yourself to a hospital system or anything like that at one point. But how do you explain that? It's not the easy street that a lot of them look at. You got to put some work.
They're just not going to do it.
They're just not going to do it.
They will look you in the face and tell you, "Oh, I'm not doing it.
I'm not doing that." You can say what you want, Jeff. I'm not doing it.
and that's actually why we have so many. I believe. Why we have so many other things like we're talking about a group of people that grew up on electronics.
Yeah, well, I've told them, and I'll say it again so they can listen to me, when we're sitting, maybe I'll be here, maybe I won't. It depends on if we have, new science. But what I've told these people is when 2035 rolls around and these doctors wonder why they're running around here like postal workers and stuff because they're not going to be living that life that they've envisioned because they've been replaced by automation and AI and all those things. They can remember this point in time when they didn't fight for themselves in this space. Because tech is coming to the medical profession. It just is.
Just like it has come every place else. Don't we remember when the mill had 20,000 workers and now it's 4,000?
Yeah.
And so automation.
Yeah.
And especially in those dangerous areas.
Right.
Temperatures are high and things like that. robotics.
Robotics.
AI.
Yeah.
And so it's here now in medicine. The technology is there. Started with electronic medical records. We were writing in paper charts.
Right.
Now everything is digital. We put our information
Yep.
into cyberspace.
Yeah.
And, robotics, the operations now are being done by robotics, some of the operations. I mean, there's still a human person there.
Yeah.
There's still a doctor, technicians present, to
But
take
once
care
they
of the
take
machine.
diagnostics from you all, meaning that for patients, we walk into offices or businesses and we simply just disrobe and get into these tubes and allow the imagery to kind of come up. And once we take the diagnostics from y'all, it's over.
The Jeffersons are real. Remember
The Jetsons. The Jetsons.
Yes,
They're absolutely real.
It's real.
Yeah.
We might not be up in outer space, but it's coming. And actually, some of that technology is here.
It is here.
There's a prototype. I believe it's in Chicago.
Yeah.
That you can go into this very nice space.
Yeah.
And disrobe and walk into a machine.
And it'll just analyze you and scan you, take the diagnostics away. Oh my goodness.
So it's a prototype, but it's coming.
Yeah. So
things start out, they're very expensive.
Of course.
But once they come to the commercial market,
they get very cheap and people start to use them. There you go.
Exactly.
I'm telling you, listen, you young medicine people out there, start to pay attention. We're talking with Dr. Jan Seabrook. We appreciate her kind of hanging out with us this morning. Let's get into this season that we're in right now because I think I talked to you on the phone a couple of months ago when you called in. We were talking about RSVs. And, obviously the flu virus is out here. Now, the flu has really been trying to get its attention back. Like y'all been talking about COVID. I'm still out here. I'm going to jump up and do a little weightlifting. I don't know if it's the flu on steroids, but there's a nice little strand out here that's doing some serious damage. And once again, you got RSV, which I used to see or used to attribute to younger people. Now it's kind of made its way into the mainstream as well. And oh, by the way, COVID's still out here. And so what do how do you navigate this as it relates to public health?
And so it's extremely difficult, especially with the challenges that we went through with COVID. And you are correct. When we were in the height of COVID, the number of flu cases were down because we were, doing the safety measures and practices and things like that. And as we're getting back into, our routine and normal behavior, we're seeing that the flu cases have increased. The number of people typically who die during a flu season are about 65,000 across the United States, between 65,000 and 68. And when we start to get into the high 70s, we know that we're having a bad flu season. On average, about 250 to 300 children under the age of 2 will die of influenza during any typical flu season. But as you said, now we have, this triple.
Yeah, it's like a triple. I mean, the viruses are really stepping their games up. I mean, put your pathology hat on. I mean, is there something going on in the environment that's stimulating these? I mean, listen, we knew the influenza and even the coronaviruses. After a while, a virus's job is to go out here and find a host. So it's always going to mutate and make some tweaks because if it doesn't, it doesn't exist. But to see it bump these viruses and pathogens bump their game up at the rate that they're doing, is there something else going on, or what are you hearing from the researchers?
So this is what I want to say about this. What I think is coronavirus, when it entered in, it was something that unlike anything else that we had ever seen.
But we had coronavirus out there in existence.
Coronaviruses have been in existence. Don't get me wrong about this, but this was a new coronavirus. And let's think about the Spanish flu of 1918.
Yeah.
And the millions of people that died worldwide because of the Spanish flu. And I think that, we are seeing something that said, do we know what happened before the Spanish flu?
Right.
We had the plague, bubonic plague in the 17 or 1800s.
Yeah, somewhere around there.
So I think that as we kind of evolve, the viruses are evolving with us.
Yeah.
And so we're going to be suffering, I believe, continuously with, the mutation of viruses. And then I think we cycle out in every, century or so, we're going to see some type of crisis like we had.
Right.
You and I won't be here.
No, but I know what you know. And so let me get your opinion. I think, once again, I think I picked your brain on this back during the COVID virus when we talked. And I know I was trying to pick Roland's brain on this as well, because we were starting to hear a lot about herd immunity. And I remember specifically in a class being taught about that. And this was the idea was is that, you know, if you're, let's just say, a bovine or you know, where you're a veterinarian, you're serving like cattle. There's no way you can go out here and theoretically immunize every single cattle, in particular in a 2,500 head or something like that. So the idea would be that you would go out here and try to see or evaluate some of the lesser ones, start to vaccinate as many of those as you can, and then allow the virus to run its course through the rest. And then you'll try to take your chances with the casualties. So when we started to see about the COVID-19 pandemic, before we even had a vaccination that was available, we were starting to hear about that because, of course, the CDC and other health offices were putting out, okay, younger people are probably going to be they have a sturdier constitution. So we're going to kind of allow them to be the front lines. Ones we need to look at are people who have their immune system compromised for sure, the cancers, the lymphomas, and then obviously our seniors. And then all of a sudden it just kind of started to move backwards. And now we need to worry about people who, you know, were in their 50s or people were in their, and then it was just like, you know what, how about everybody kind of look out, you know, because this thing is getting out of hand. So does that, and so where I'm going with this is I'm asking you as a scientist is, does this kind of lessen from a big impact, a big sample size? You know, I know you can think community health because of course you do community health. So I want you to put that hat on. So does that lessen the impact of having herd mentality work when you basically go out here and immunize everybody and don't allow the natural antibodies to go out here and provide the defense that we normally do as human beings?
I wish that we had not put that word into the existence of the general public.
Right.
I know that it had, you know,
it has a place
in the scientific community, and when we're working with, you know, on the veterinary
side, it has a place.
Husbandry, but so.
In human medicine, what you're saying is it really got misused.
It did.
Yeah.
And so what we try to put typical scientific thought processes with, you know, when we look at the general healthy constitution of children,
right,
adolescents, and typically young 20 to 30-year-olds. And so let's focus on, like you said, the immunocompromised,
right,
those with chronic diseases,
yes,
the extremely elderly, 80 and above. And the general population that's less than 50 should be okay. Typically, they're okay. Well, this was an atypical virus that through all of those
right,
normal scientific thought processes that we normally use when we're confronting a new virus.
Right.
It did not fit any. It's like a puzzle piece that
did
not fit any place. And so we had to go back and rethink. So typically, with vaccines, and let's just put COVID to the side.
Okay.
If you get 80% of children in one classroom immunized, then you're good.
Then you're good.
If you cannot, and we could not with COVID, get to that 80%, that herd immunity is out of the window.
Okay,
it
now
can't even come into existence because if you don't have 80%, and that's 80% of the population of the United States.
Right. It just didn't work. So let me ask you this.
Herd immunity, open the window and throw that word out because throw those words
out. So let's bring it back to something that obviously, you know, I know my grandparents, my mom never did this with me, but you lived in the South, and this is something that's very rural. And I can remember hearing stories of my cousins and my aunts down in the South back when measles and chickenpox would happen. What would happen is one of my aunts would call the other and say, you know, bring your kids over here, let them all get this chickenpox right now, and then we'll be done with it, and kind of, you know, they'll build their immunity, and we'll go out and, you know, kind of live to fight another day. What do you say to that? I mean, is there a place for that? Was there a place for that during the COVID epidemic, that mentality? No.
There was not a place for that because COVID was killing people.
COVID was killing folks.
COVID was killing people. And now we're starting to see a resurgence of viral illnesses that we had control of, like measles.
Yeah.
So we're starting to have measles outbreaks now because not only are people refusing COVID, they're starting to refuse more people. We had a small subset
that was anti-vax, right?
Right. That has grown, and it has kind of sloshed over
Yeah.
into those vaccines that children need to have to go to school.
Right.
Now, we can go back in the record books and in cemeteries and see
Yeah, the results of that.
Right, smallpox,
Yeah.
And other illnesses that we vaccinate people for now were actual killers of the population. And I'm talking, 1700s,
Absolutely.
1800s, 1900s, until vaccines were discovered and started to be used.
Now, were these vaccines, now that we're looking back and we obviously have more science and we can understand the DNA and the RNA parts of it, did the vaccines, were they used as kind of, I guess, the fighters of the viruses, or did they go out here and boost something up in ourselves that we ended up kind of adapting to as human beings, and that's what eradicated or at least made a lot of these viruses less lethal?
Right. So let's talk about polio. Remember polio?
Oh, absolutely.
We've eradicated polio in the United States, but if people start to refuse the polio vaccine for their children,
it will come
we're
back.
going to start to see increases. India, Africa, places like Indonesia and things like that, they still have polio in some of the indigenous areas.
Yes.
Because we visited and brought them, brought those diseases to them, and they aren't immunized against them. So we're starting to see cases of polio in third world countries. And so what I'm trying to say is those cases can start to increase here in the United States when we start to refuse vaccines that we know prevent these serious illnesses. So when Sabin and Salk created the first polio vaccine, President Roosevelt had polio.
Yes.
The children were in iron lungs at that time.
Yeah.
Polio was...
It was lethal.
It was lethal.
And what was worse is if you lived with it. You get what I mean? I remember reading sometime where one person who had polio or had a family member, this was actually in literature, they were wishing him death rather than to live with polio because it would scar you. It would just make your life miserable.
Yes, so here we've eradicated the disease. That's what vaccines do.
Okay.
And so, getting back to your question, it helps us build up immunity. So when the virus is circulating, we're able to
kind of fight it off. Yeah.
And so as that population of unvaccinated people increases, we're going to start to see an upsurgence of diseases we have pretty much eradicated and controlled in the United States.
So, kind of before we finish this subject, because I know you're busy, but so what made COVID, as we kind of look back and we know more now, and as I said, the coronavirus in some of its previous forms had really always been in existence, but what made this COVID-19 thing so lethal? Was it that it got inside your body and just started mixing around with finding out what ails you and exploiting some of your weaknesses and taking it to like the 10th level? What was going on with COVID?
And so with COVID, and I just remember back to when that COVID was first being talked about.
Right.
It was called novel.
Right.
Novel.
Right.
Novel means new.
Right.
So our body had
never seen
it before. So it learned us, and our body took a long time to learn COVID.
Right.
And so that's why it was able to impact us, and it didn't matter your health status,
your
age, or anything. It was taking everybody out.
Yeah.
Because as it was learning, it was figuring out where it needed to. Start with the lungs,
the
throat and the lungs,
right,
and then it was able to start impacting organ systems, heart.
That's what it seemed it did. It seemed like it seemed like a bug that got in, and as you said, it didn't matter what but it quickly sized up your DNA. And listen, if you were obese, it exploited that. If you had little minor heart conditions, it exacerbated that. If you were diabetic, it just seemed like it figured you out very quick and realized your weaknesses, and that's kind of what it went, and that's why people were dying at such a rate when they came in contact with it. Because I remember I got it, and it just felt like it was the worst cold ever, and I know some people that have had it now, and they still don't have their sense of smell back.
So, I'm going to bring one topic up, HIV. Remember,
yes.
HIV was a novel
it was
virus.
Right.
Back in the 70s, 80s
when
it was first diagnosed. And it killed off millions of people.
It ran through people.
Before we got a handle on
right.
it. And were able to find, now we even have, they're working on a vaccine for it, but we have it down to one pill. And there used to be a series of almost 20 pills
Absolutely.
you had to take. And your muscles started wasting.
Yeah.
And just so think about that. And when you think about it in that context, it was new and it ravaged people's bodies until scientists were able to figure out how to combat the virus with antiviral medications.
Absolutely.
And then once they were able to do that, then they were able to look at different combinations of medications to help bring the viral load down.
Wow.
Because when you have a high viral load, that's when you are most vulnerable,
right,
to any virus.
Yeah.
You have a high viral load, so we try to reduce those loads with antiviral medications as quickly as possible. Because as we reduce those viral loads, then it gives your body a chance to get healthy and start to fight off the disease.
See, listen, I hope you speak to children. I know you do. I mean, but you and I were talking earlier about the medical students and things like that. But just sitting here listening to you, just kind of explain and really just kind of talk about what's going on in medicine and things like that. It's very intriguing, not just because I love medicine, but you really kind of explain it so well. And as we talk about young people are trying to figure out where they're going to fit in life, whether they want to go out and be a medical doctor or things like that, we need talented people in research. We need talented people that look under the microscope. We need virologists. We need people that want to get into pathology. I mean, some of these things can be entertaining to the right person that's exposed to it. I mean, some people find germs fun. I don't, but some people do.
But and speaking of that, because I know your previous guest, we also need students in tech.
Yes.
And we need them to go into tech.
Yeah.
They need to invent equipment. Fix equipment, repair
Thank
equipment.
you.
So, I mean, the space, is enormous as far as, where you could potentially fit in healthcare. You may not be the doctor, the nurse practitioner, the physician.
It's intimidating sometimes when you think about what you all go through to be a doctor. I mean, now and I can understand these young people, as you just pointed out, because we live in such a microwave society, and I don't think people really understand that once you get that acceptance letter and you decide that you're going to go into medical school, that you're probably only going to see your fellow students in your cohort as far as your only social interaction, because you got to put the hours in. There's a lot of sacrifice for you to come out on the other side. I very much appreciate all of you all who really did it and go out and get that medical license. And it's constant pressure. It's operating under pressure. And you do it because you like and you believe in what you're doing. And so, I mean, it's not built for everybody, and thank God for that. Because, I mean, I'll be honest with you, I don't want just anybody being a doctor. I don't. And I always make jokes about that. They're like, it's just about grades and things like that. I'm like,
no.
do you want a doctor or a person operating on your most precious cargo, your mother, your father, your children who was just barely making it in school? Or do you want somebody that really pushed themselves and was challenged and pushed and came out on the other side like a diamond? I want the diamond. I'll tell you that much. I don't want the coal. I don't want them. So I want to just tell you, I appreciate. Give us some community health net information.
So you can go to our website, chn-indiana.org. Our phone number is 219-880-1190. We have 8 locations throughout Northwest Indiana. Our main location is 1021 West 5th Avenue in Gary. Our Martin Luther King location right across the street. 3503 Martin Luther King. 1015 North Shelby Street in Miller.
That's
our
right.
Pediatrics only location.
Isn't that Dr. Simpson's old office?
Yes,
okay.
and Dr. Simpson is still hanging in there with us. He semi-retired.
He's never gonna quit.
Yeah, we had Dr. Lavelle there seeing his patients and also taking in new patients as well. And Dr. Simpson, he's in residence.
Yeah.
He checks in every now and then.
Nice.
Covers for Dr. Lavelle when she's out of the office.
Right.
So he's still there.
Okay, living the dream.
Yes. On his own terms.
There you go.
Fine by us. 3900 Calhoun Street in the Calumet High School, Tech High School. It's open to the public as well as the school district. 6100 Broadway in Maryville.
61st Avenue.
Yes.
Yeah.
And then, 5927 Columbia Avenue.
Yeah, Hammond.
And then we are also in the new Hammond Central High School.
Wow.
That is only for the school district and the students. And then we're at Hammond Morton High School.
Oh, so, what's up with Westside? Has that kind of gotten moved around a little bit?
It's coming in 2024.
Okay, good.
So we're excited about that.
Yeah, absolutely. We're excited about you. We love doing these segments. I want to thank you for taking time so we can do this, because I'm always interested in picking your brain. As I said, I know you do talk to kids and things like that, but I want to emphasize that, you're a valued asset to the community, because we got a lot of young people out here that are smart, maybe not as inspired maybe as they should be, but you know, I guarantee you that you're an asset that they should come across as we create new leaders and future doctors or whatever it is. I'm just saying you're positive.
Well, thank you. I appreciate you saying that.
Yeah.
And I hope that they come along very quickly because I see we're getting tired. Okay? Getting tired.
You get tired. All right, Dr. Seabrook. I enjoyed this. We're going to get ready to take a break. When we come back, we'll get a look outside, weather, and traffic. Also get you updated with some of the news. And, of course, on this wonderful Thursday phone calls. You're listening to Wake Up GI with Jeffrey Smith right here, 88.7 FM, WGVE.
You're listening to the new #1
Good
morning
stuff.